Hi, everybody. So we're going to talk about attention and consciousness and problems relating to those. So attention is selective awareness of a part of the environment. You put a mental spotlight on it. Is attention conscious? Are we aware that we're attending to something? We might not be always aware of what we're paying attention to. Nonverbal processing is a big example of this. And we're going to talk about problems of attention and conscious awareness in this PowerPoint. Consciousness is awareness at the primary level, but it can also be awareness of awareness, which seems weird, but like essentially you're aware that you are aware of something. It's sort of been argued whether consciousness and attention are the same thing, but neuropsychologically, they're different. So inattention can be quite a problem. So inattentional blindness is failure to notice something that occurs during the performance of another task. And you have change blindness that can be related here, which is failure to detect changes in the presence, identity, or location of objects in scenes. There's great videos about both of these. So really look forward to you all taking a look at those. And some of them sort of test you to see what you recognize. Attentional blink is attention to the first target prevents awareness of the second one, even if it's conspicuous. So, you know, we can be interrupted in our ability to attend to something. So neglect is the big thing that we've talked about in this chapter, and your Ogden case study focuses on this. It's such an interesting thing that can happen. So contralateral neglect is neglect for visual, auditory, and synesthetic stimulation on one side of the body or space. So this is sometimes called constructional apraxia. So it's impaired in combining blocks to form designs. You have impairment in drawing and cutting. You can have topographic disability where you can't draw maps from memory. And during recovery, if recovery is possible, patients go through alesthesia, where they begin to respond to stimuli on the neglected side as if the stimuli were on the other side of the body. And then you can have simultaneous extinction, which we'll talk about later in this lecture. So this is what neglect looks like. A lot of what we do here is have people draw things. And so when you draw a clock, they'll put all the numbers on one side because it's like they just don't see the other side. Or they'll draw half a house or half a flower. And again, some great videos about this in this module. The lesion is most often on the right inferior parietal lobe, but it can be other places. You can see it in the frontal lobe, the cingulate cortex after subcortical damage. It can be caused by defective sensation or perception, is a theory, or it could be caused by defective attentional orientation, or honestly, it could probably be a combo of both. So here we see a drawing of a patient with neglect. So you have a model, you have the patient's copy, and here you see, again, just ignoring half the picture. Even the house is only half the size. Object recognition is another thing that can be problematic here. They have trouble recognizing familiar objects and unfamiliar views in particular. So here you go. They would be able to maybe recognize A as a bucket, but not B. You can simulate neglect in the lab, and they'll do this by giving people prisms that shift their view, but you can also do this as a treatment for people who do have neglect, and that's what Rossetti and colleagues did. So when they put on these prisms that shifted their field 10 degrees, they had reduction in that neglect, and it seemed to them like maybe the executive attentional system may have been activated by that prism, so related to the other chapter in this module. So here you see patient, the model, and then the first copy without the prisms, right? That's what we just saw. And then copy after removing the prisms, and then copy 2 hours later. So they had attention to things in their left field that it seemed like their brain sort of got it all. And the control patient didn't have that change. So if you have a lesion in the postcentral gyrus, then you have abnormally high sensory thresholds and impaired position sense, partially as a result. You have deficits in tactile perception, and you can have something called afferent paresis, which are clumsy finger movements due to their lack of kinesthetic feedback about where their fingers are in space. So here's an example of how we might test for this. We give them, we blindfold them and give them objects, and they have to identify the pattern on that object just by touching one. A couple other things that can happen here. Asterogenosis is a disorder of tactile perception. So it's the inability to recognize an object by touch. So here's a pen. I use them all day, every day, right? If I had this, I could not recognize what it was just by touching it. I have to look at it and say, oh, it's a pen. Here we're back to simultaneous extinction, which I promised we'd get back to. So this is where two stimuli are applied simultaneously to opposite sides of the body, and a failure to report a stimulus on one side is referred to as extinction. So, you know, most of us, if we were to like put both hands on the desk, for example, we could feel both. Someone with one of these disorders wouldn't be able to do that. There's also numb touch, which is also called blind touch, where you can't feel stimuli and you can't feel touch, but you can report on the location of the touch. So this is like the blind sight that we've discussed earlier. So here's an example of extinction, simultaneous extinction. Okay, so when you have two identical objects, you only see the one in the unimpaired side. When you have two different objects, you can recognize they're both there. But if you have two kinds of the same object, so here you have like a salad fork and a dinner fork, you still can only focus on the one that's in your non-affected field. A somatognosia, there we go, is the loss of sense of one's own body. And it's most commonly on the left side of the body. So again, you just aren't aware of what's happening on that side of your body. Anosognosia is unawareness or denial of illness, which can be really problematic and dangerous, right? Diaphoria is indifference to illness, so like you recognize you're ill, but you don't really care. Asymbolia for pain is absence of normal reactions to pain, such as withdrawal. So withdrawal is you touch something hot and you go, whoa. So if you don't have that reaction, you can end up with a much worse burn, right? And then autopagnosia results from the left parietal cortex lesions and can include finger agnosia. Balance syndrome is something that is this combination of a whole bunch of things. Oh, sorry, I told you real quick that finger agnosia is being unable to point to your own fingers or to show them to the examiner if they ask you, like, show me your right index finger. You can't do that. That's finger agnosia. Now to balance syndrome. Here you have bilateral damage, and you're unable to fixate on a visual stimulus. And you have simultagnosia, that is neglect of objects. So if you turn toward one object, you can't see anything else in the field object-wise. And then object ataxia is severe deficits in reaching under visual guidance. And this is the most common symptom of bilateral or unilateral lesions in the posterior parietal region. And movements not requiring visual guidance are okay. So like if you have to button your shirt and you just know how to do that, some men when they tie a tie are fine like that, don't have to look at it, that would be okay. But if there's something you need to do visual guidance, maybe style your hair, with the use of the mirror, you would struggle with that. Gerstmann syndrome is again one of these that has a lot of combinations here. So finger agnosia for fingers on either hand, right-left confusion. You don't know which is your right, which is your left. We've talked about agraphia before, inability to write. You also have acalculia, which is the inability to do simple math problems, and disturbed language function. And this results from a left parietal lobe lesion. Then there's apraxia, and this is a movement disorder in which the loss of movement is caused not by weakness, inability to move, abnormal muscle tone, intellectual deterioration, poor comprehension, or other disorders of movement. And there's lots of different versions of this. So, ideomotor apraxia, you can't copy serial movements or make gestures. Constructional apraxia is a visual motor disorder. You can't draw pictures, assemble puzzles, or copy a series of facial movements. Deficits in drawing seem to appear after damage to the right parietal lobe. And spatial attention, the function of the parietal lobe is selectively attend to different stimuli, basically allows attention to shift. Another thing you can struggle with is mental rotation. Mental rotation is attacked where you are shown an image and say, imagine this rotated 90 degrees to the right, what would it look like? And if you have left hemisphere deficits, you might have an inability to generate appropriate mental images. Right hemisphere deficits may result in the inability to manipulate the image. And sometimes with right hemisphere damage, you also can't use topographic information. So we have lots of different ways that we can try to test for this. Tactile form recognition, you have to manipulate blocks and place them in holes. Contralateral neglect, you mark the middle of a line. For visual perception, you have them name incomplete figures, and test especially sensitive when you have damage at the temporoparietal junction. So both things are kind of implicated there. You can do a right-left differentiation test. And then for language, you can do token tests for language and reading comprehension. There are no standardized tests for apraxia that are analogous to this, though. So here's some of the movement things you can have people do for apraxia. Have them do simple tasks. And then you can do things like, where can they distinguish touch? How close can they distinguish it? How far apart does it have to be for them to recognize there are two touches going on? Here again are a list of those neuropsychological assessments you would be able to use. All right, hopefully you enjoy the rest of this module. Again, check out the videos, especially the ones on the attention blindness and changes. You're gonna really